So, welcome to today's discussion about the coronary blood supply. Today, we are going to look at how the heart supplies itself with blood. First, let's look at where it all begins. The entire supply line starts at the very base of the aorta, which is right here, the largest artery in the body. So, right at the exit of the heart, there are small openings called the coronary ostia, right here and here. We can see the right corresponds to where the right coronary artery exits, and the left coronary ostia corresponds to where the left coronary artery exits the aorta. So think of this like the first exit on this massive blood vessel, the aorta. So it ensures that the heart gets the freshest, most oxygenated blood before any other part of the body. So this opening sits right here just behind the aortic valve leaflets. We've got the leaflets of the aorta here you see and the coronary ostia just behind the valves here. It's important to know that the heart actually receives most of its blood flow while it is relaxing between beats. This is termed the diastolic phase. So it doesn't receive blood while it is squeezing. So think of it logically. The heart myocardium is a muscle. So during its contraction, systole, there is an increased resistance within the myocardium, which limits coronary blood flow. However, during diastole, the heart relaxes. As such, intramyocardial pressure reduces and thus coronary blood flow occurs. So, moving on to the left side of the heart, we find the left main coronary artery. So this is a short but vital vessel that quickly splits into two main branches, as you can see. This system is responsible for supplying the bulk of the heart muscle mass. So the first branch is the left anterior descending artery, which runs here in the anterior wall of the heart all the way down to the apex of the heart. While the second branch here, the circumflex artery, which wraps around the left side of the heart like a belt to feed the left atrium and parts of the posterior wall of the heart. Let's move on to the right coronary artery. The right coronary artery travels down the right side and it supplies the right ventricle. We cannot ignore the right marginal artery, which runs along the right margin of the heart and supplies portions of the right ventricle as well. And finally, the right coronary artery runs and wraps around the heart posteriorly to give the posterior descending artery. So now, while the arteries we've discussed so far cover the front and the sides, the posterior descending artery is the primary supplier for the back and the bottom third of the heart. So the posterior descending artery runs along the back of the heart in a groove called this posterior intraventricular sulcus. So now here's the thing with the posterior descending artery. It is it isn't always a branch of the same artery in every person. This term is what professionals call coronary dominance. In about 85 to 90% of people, the posterior descending artery branches off the right coronary artery. This is a right dominant circulation. And in about 10% of people, it branches off the left circumflex, making them left dominant. So a lucky few people even have what is termed a co-dominant system, where both sides contribute to blood flow. So why does the PDA matter for an EKG? Because the PDA supplies the posterior wall. And this is the hardest area to see on the standard 12 lead EKG. Since we do not put EKG leads on the patient's back, A PDA blockage won't usually show an elevation on a normal EKG. Instead, we should look for reciprocal depressions in leads V1 and V2. Think of it as looking at the heart backwards. If you see a dip in the front leads, it might actually be a reflection of a myocardial infarction happening in the back, in the territory of the posterior descending artery. So, up until now, we've been talking about how oxygenated blood goes into the heart, but how does this used blood, deoxygenated blood, leave the heart? So, this is where the coronary sinus comes into play. So, after the heart muscles uses up all the oxygen, the deoxygenated blood is collected by a series of multiple cardiac veins draining the heart. So these veins all empty into this large channel we can see here on the back of the heart called the coronary sinus. Okay, on the also the posterior surface of the heart called the coronary sinus, I would say. So finally, this deoxygenated blood in the coronary sinus empties into the right atrium to join the heart circulation. And as we well know, the right side of the heart typically carries deoxygenated blood. So now we've taken time to speak about all these coronary blood vessels that supply the heart. Now, why does knowing all of this matter? Because occlusion of these vessels during a myocardial infarction reflects on the respective leads on a standard 12 lead EKG. We've already seen the pink slip medical students hate very well. So let us master the coronary arteries and the EKG correlations using this table. So this table shows the major branches of the coronary arteries, the heart region it supplies, and the EKG leads that are usually involved when there is occlusion of the respective blood vessels. Beginning with the left main coronary artery, so we know it supplies almost the entire left side of the heart. There are EKG changes on almost everywhere on the standard 12 lead ECG. And next will be the left anterior descending artery, which is a branch from the left main, supplying the anterior wall and the septum. There will be EKG changes on the anterior leads, such as V1, V2, V3, and V4. The circumflex, which we know supplies the lateral wall, and EKG changes will be seen on lead 1, AVL, V5, and V6. Then the obtuse marginal, which is very specific for the lateral wall, we'll see changes on lead 1 and AVL. Then the acute marginal, a branch of the right coronary artery, supplies the right ventricle. We should see changes in V4R, which is obtained by placing the V4 electrode in the fifth right intercostal space. Now, the posterior descending artery, which you know is a very major artery, supplying the inferior wall of the heart, we will see ECG changes on lead 2, 3, and lead AVF. The posterior wall of the heart is also supplied by the posterior descending artery, which in typical cases, changes will only be seen in V1 to V3 as depressions whenever there is an infarction of the posterior wall of the heart. So in these cases, additional leads such as the V7, V8, and V9 is used. We've come to the end of this discussion. Thank you for listening in. I hope it was informative.